So my background with lifelong medical care, member of the Master Plan on Aging Stakeholder Committee, and co-chair of the Health Work Group. And, we essentially, as you can see, tried to cover a combination of integrated home and community-based care with healthcare, geriatric training, preventive and healthy living type of approaches, as well as other things. So a fairly complex discussion. But today, obviously, we're trying to figure out what do we do locally? What can we do locally to move this forward? So I'm missing my cameras right now, Sarah, but maybe you could
Sure.
say a few words. There you are.
Yeah. Hi, I'm Sarah Levin. I'm a physician at Contra Costa Health Services, one of the deputy health officers. Have during COVID times was the health officer at the health department who was leading the task force to address the particular needs in congregate care facilities, with attention obviously to our residential care facilities for the elderly, our skilled nursing facilities, and our boarding cares. As well as I work with clinically with our healthcare for homeless services, of which we have a large growing population of elders in our shelters and our respite centers. So very much seeing on the local level, Contra Costa, how important it is that we start to have more health services that are appropriate to this aging population, with all the needs that and services that are required to help them age with dignity and as in the best way that they can. Debbie asked me to co-facilitate with Marty and Jenny on this. I think what we're looking to do is come up with, at the end of this discussion, with 3 goals or three priorities in the initiatives of Health Reimagined. So I hope everyone's had a chance to look at the Master Plan on Aging, and there's obviously a ton of initiatives within each of the goals in that category. So I think hopefully we'll be able to come up with 3.
Jenny, do you want to say a couple words before we just open it up?
Thank you, Marty, and thank you, Sarah. Why don't I just do this? I'll list the subtopics that are under the big category of Health Reimagined. So as people think about what they would like to contribute, there's 7, and number 1 is bridging healthcare with home. Another one is healthcare as we age, which means more healthy aging. Lifelong healthy aging is another topic. Geriatric care expansion, dementia in focus, and innovation in nursing homes. So these are kind of the big subcategories. Don't worry if what you are thinking of sharing, doesn't quite fit. We'll make it happen. And just underscoring that, needless to say, we have such a short period of time. If there are things that you want to contribute, we'll make sure that this group is being recorded, as every group is. So your thoughts will be captured. Back to you, Marty.
Okay, let's open it up. Sarah, is that okay?
Yeah, great. Let's do it.
So what are people thinking? What could we do locally that would move the needle on this whole area of health in some of the sub areas that Jenny laid out for you a second ago?
So I could just make a comment. For me, I think that opening up and taking a look at HIPAA restrictions, rather than having a way to facilitate the sharing of databases from healthcare plans to nonprofits, would really help us serve underrepresented communities, because it's the health plans that have the list of those folks who live alone, who are poor, and who need assistance. And I have found that to be a barrier, especially during COVID, when I wanted to connect the health plan data to Meals on Wheels.
Uh-huh.
Because they knew the pocket of poor elderly folks in East County and I couldn't access it.
Uh-huh. So cracking that issue of health plan data tied to broader social service and social service for the elderly. Yeah.
I had a question. A question,
Go for it.
maybe for me to frame this issue better in my mind anyway, is what does the data say is the most pressing need for the elderly in terms of healthcare? Is it access to healthcare? Is it underlying conditions, comorbidities, chronic conditions? What does what's the most pressing issue we have now? So we want to address these, fairly urgently. As after all, these people are in their 80s, perhaps, or 70s, 80s, whatever. And so these things that we address should be addressed pretty soon. I mean, there's something we address that are systemic and for a long term. And this master plans of aging is a long-term deal. But it helped me in a way to understand what needs to be done pretty soon.
Uh-huh.
Hi there. Hi there. My name is Rob Tufel. I'm the CEO of Cancer Support Community. You'll hear me constantly bring up cancer as an evangelist for cancer and aging. I saw dementia listed on there. I did not see cancer. Majority of people diagnosed with cancer are older adults. As a matter of fact, people say we shouldn't talk about geriatric oncology because all oncology is geriatrics. It was related to older adults. By 2040, 73% of all cancer patients will be 65 years and older. Older cancer patients get less chemotherapy than younger cancer patients. So for me, cancer and aging are linked. Cancer is a disease of aging. And somehow, I know we're not talking specifically about diseases, but I would like to see somehow cancer come up. It was not in the master plan on aging at all. I was really surprised to see that. And we're going to see more and more and more older adults who are cancer patients. So that's something I would like to see addressed.
Hello, I'm
I'm
Lillian
Nina
Roslin.
Rimachwala, and I have noticed, or we have noticed, that caregiving in nursing homes was disastrous during this virus thing. And one would like to see that there's not too much profit-taking attitude in taking care of seniors. And maybe we need a law passed that nonprofits only should be allowed to run nursing homes. Otherwise, nowhere can you see that profit is a motive to take care of people. But that's my feeling.
Uh-huh.
Hi,
So questioning the profit motive. Lillian, you were going to say?
Yeah. I wanted to piggyback on Barbara's suggestion around technology and connecting healthcare providers with other social service providers. I'm executive director with the John Muir Community Health Fund, and we're currently partnering with Contra Costa Regional Health Foundation to support a community information exchange program for Contra Costa County. It's a community planning process that's underway, and that would be a very quick pivot now to get MPA people involved in that process.
Well, Lillian, that's fantastic, because my biggest concern is that electronically it's so fractionalized that when a patient goes on to try to find, their doctors or hospitals or even any of their medical history, it's just so difficult because it's not connected. So
Right.
I would like to
also
see
then having to tell a patient, a client, having to tell his or her story over and over again to each individual. What's your name? What's your, all of that. So it's an opportune time and something, again, that I think we could get involved in very quickly.
Yeah, that's fantastic. So yeah, but I would like to see it beyond just John Muir. I think that they should
No,
connect.
it's countywide. It's
Yeah.
countywide.
Okay.
We're a foundation that's supporting all of the community based organizations and county and nonprofit clinics and the hospitals connect. So it's not just John Muir.
Can I ask you a question about that, Lillian? In that group that's forming, are there the other large providers participating in that process? Kaiser, et cetera? Yeah.
That's their next step. They just launched, they're finishing up their first 6 months. Health Leads and Contra Costa Crisis Center were the two lead organizations, and they are about to approach funders again for another round of support for this community planning process. And I believe they are engaging them with the health services providers.
Right, but you're talking
Fantastic.
about
I see
over
Cindy
here.
has her hand up. Can we,
Okay.
Cindy, I see both
Thank you.
electronically and I can see you. Go for it.
Do away. Two comments on the health exchange. And I'm going to speak for Debbie. I'm the CEO of Hospice of the East Bay, and I will speak for Debbie as well, that when we do these health exchanges, we have to remember the community groups that are also providing health services to these people. We have a difficult time getting information about patients. And then with my hospice and palliative care hat on, I'm going to say that we need to really focus on goals of care conversations. I think what happens with elderly is that we are going to, people have these, what the person wants and what their children want are not necessarily the same thing. And we need to have those frank conversations with seniors so they don't get involved where they go to the hospital and they start all these treatments and everything that they really don't want. And so I think that's a really key piece of getting those goals of care conversations, having them and documenting them.
Great, Cindy. Thank you. I see Beth has her hand up.
Hi, thanks so much. I wanted to concur with the comments around interoperable data systems. But I think that our experience, I work at the county, Contra Costa County, and I think our experience is that I think a lot of the systems really need to be focused on those systems to the smaller CBOs, the smaller assisted living facilities, RCFEs, and board and cares. I think COVID was a very illuminating experience in that a lot of the smaller RCFE board and cares, it's not a technology hub. They aren't a nursing home that has systems, and even just getting information on lists of what people are living there could be very cumbersome. And when you're looking at something like communicable disease, it was a very difficult process to just collect just basic information on testing and things along those lines. So I guess I would really advocate that we really look to use the master plan on aging on developing the infrastructure for some of the smaller RCFEs, getting some data systems in place for those systems so we can know who's living where, being able to share health information and to kind of bolster those places in the entire continuum of care.
Thank you. Terry, and then Vi or V. Yeah.
Okay, thanks. I was talking to Jenny a little earlier on chat about how difficult it is to find a geriatrician, and we have plenty of clients that need geriatricians, but there are so few. So I guess my question is more a discussion point. How do we encourage physicians to gear themselves towards that population? I mean, there's not very much monetary incentive to do so. So that's, one point I'd like to discuss with the group. And then secondly, are there any links, Sarah, to geriatricians or people that have patients that patient populations of older adults?
By the way, we should, Sarah, before you answer, we should just say in the master plan and the follow-up to the master plan, there are at least a few million in the governor's budget proposal that's still being negotiated. The final budget is still being negotiated unless they finished it this morning. That would go towards geriatric education with OSHPD, which handles a lot of the different types of training and loan repayment sort of programs for the state. So FYI. Sarah, did you want to answer more on that?
Sure. Yeah, I mean, it's a huge problem throughout the country, and starting with the pipeline and medical education. You know, all of us who've been trained as doctors can say it was just ridiculous. And I think Louisa Aronson spoke to it, how little training there is in geriatrics as part of standard medical training. So that's something on a policy level that really needs to happen within medical education, and all the other disciplines in the health delivery systems, in terms of creating, recognizing that there needs to be new models of care for elders. But what Marty's referring to, I think, maybe, you know, if we want to make this one of our priorities within the initiatives, there is, you know, within the goal of geriatric care expansion, there's expand geriatric emergency department certification and increasing the geriatric training opportunities with multidisciplinary teams that include nurses, social workers, community health workers, gerontologists, and geriatricians. So I wonder if that may be something, just putting that out there, because we are going to have to narrow down to 3 areas that we want to put forward. Within that too is the initiative to try and increase advanced geriatric training for advanced practitioners, so nurse practitioners, physician assistants, who also can provide a lot of the primary care with that.
I think we have, is it Vi or V next?
It is Vi. Thank you. So I'm staff for the Developmental Disabilities Council in Contra Costa County. So that is much more my expertise versus aging. But I wanted to connect with something that Cindy mentioned around what a patient wants, maybe not being aligned with what their children want. And this makes me think of the notion of that is heavily involved in the disability community, which is person-centered thinking and person-centered planning. So this is to say that a person with very significant barriers to communication or cognition can still drive their own ship in making decisions for themselves. And as a person ages, the person aging needs to be making their own medical decisions, irrespective of what, you know, their kids may want. And that's hard for people to hear. But there are ways to do that. And so I guess my wish here to add to the list would be to embed those notions of person-centered thinking and person-centered planting in healthcare as we age.
Good point. Thank you. Beth has her hand up, and then Barbara after that. Beth, you're on mute.
Sorry, I forgot to put my hand down.
Oh, you're good? Okay. We'll go over to Barbara then.
So,
Barbara?
I know we're supposed to be focusing maybe on today, but I know there is discussions in the state regarding the availability of long-term care for everyone as part of the health plan. And I think that's a critical piece, so that people who have never planned for that and don't have a long-term care health plan, that's going to be an available option to them in the future.
Barbara, I think we should probably clarify, and maybe Jenny can help me on this one. Really, the master plan asks for eventual universal long-term services and supports coverage, probably with help from the federal government. I think the closest we get to seeing that integrated into a health plan would actually be the state's CalAIM program that's going to ask counties to build dual eligible SNP programs for those that are both, or special needs programs for those that are both on Medicare and Medi-Cal, but not until 2025 or 2026. And that might move in that direction. And then, of course, the other issue that Jenny is well familiar with is we'd like to see PACE programs be available to every area of the state. And you know they're not now. CEI, of course, has just started in Contra Costa County more, but we have work to do. Jenny, did you want to comment on that one?
Well, I think, as you say, Marty, there's a long road ahead in order to do this, but the wish would be that people would have the services and supports that they would need to be able to stay as highly functional in the community as possible with their preferences. And so that is kind of under this master goal of Health Reimagined, because right now this doesn't really fully exist, as Marty points out.
Thanks. Okay, let's keep going. Who's Terry, are you raising your hand or just have your hand here? No. Okay.
I see there's a hand up from David Bennett. I'm just not sure if you're able to see all the screens at once, so I want to mention that.
No, I can't. Go.
Thank you.
I can see the electronic hand raised, but I can't see all the faces.
This is Elaine Welch. I don't know how to electronic hand raise. I'm listed on the screen as David Bennett.
Yep.
That's a
We
long
gotcha.
story, but anyhow, nothing personal happening to me. I wanted to bring up something that's extremely important to me because I deal with it every day, and that's mobility management, transportation. I work with seniors of all ages. We have people, I have 12 people on my program over age 100, and were it not for the programs we have, they can't get in for medical care. They can't get in for anything. They are isolated to their home. And, you know, we keep saying aging is not an illness, but there is so much illness associated as we get older that these people have got to be put in the presence of a caregiver, not a caregiver, but a care provider. I'm going to be 75 this year. I had my first physical by phone this year. And because of COVID, it was an interesting experience. No one touched me. No one listened to my heart. No one looked at the edema in my ankles. And as a nurse, I just found it very humorous because fortunately I'm very healthy, but I have so many clients who are not healthy and they've got to get in for care. During COVID, it was a nightmare for those of us trying to do one-on-one transportation and escort people in because we were told we had to stay 6 feet away. We had to go through a lot. I had doctors calling me saying, I've got to do this injection in her eye, help us. And what we went through to make that happen with nobody covering the transportation and so many different kinds of transportation that needed to be met. We are taking those that need door through door escort and stay with them and bring them back home. And somehow in all of the access to care, I feel transportation gets kind of swept under the carpet and hoping somebody's going to do it. I want to give it a forefront and make sure we're here ready to help and we have great ideas.
Shout out to transportation and health. Yeah.
Yes, this is Jenny jumping in. You know, many rules were loosened or different ways of caring for people or providing access happened during this past, 15 to 18 months. And I'm connected to another system, the Scan Health Foundation. And we're actually summarizing all the things that are feasible when we lifted kind of the traditional rules to see if we can make these things more accessible for the future as a permanent option. And one concrete example is that there are paramedic systems now that can actually make visits to the home, going back to the ability to do that. That's temporary, but these are some examples of maximizing some of the flexibilities that occurred over these past 15 months and seeing what's important to perhaps keep going in the future, because it made things easier for people who couldn't get out, for example. Marty and Sarah, I know we're supposed to come up with 3 and for our recommendations, and so we have definitely a great list, but can we think about the report out at least for the next year? Are there some areas we want to prioritize?
Yeah, I was hoping, Jenny, that Sarah might help us too, because Sarah's going to report out. So I figured the pressure was on her to try to help synthesize what people have been saying.
I thought we would help together, help Sarah in this process.
I was ready to leave her on her own.
So let me say from what the discussion was today, this is sort of what I'm pulling out, and within the structure of the goals and the initiatives under our Health Reimagined. There's going to be opportunity for people that feel like the priorities didn't get addressed. So, but Initiative 49 and 50 are highlight to Medi-Cal plans and providers the value of palliative care to improve patient outcomes and support patient and family choices for care. And Initiative 50 is identify ways to promote care wishes, such as advanced planning directives and physicians' orders for life-sustaining treatment for all ages. That came up with a few people that spoke to that about improving the goals of care discussions and being able to do that. So I'm thinking that those two initiatives could be one of the priorities. The other main theme that came up was about expanding data systems and coordination of care, building data infrastructure, coordination of care. And I think that falls within one of the earlier initiatives, which is really coordination of care and improving extension of services, community-based services, and organizations between health delivery systems and CBOs under the CalAIM. So I'm thinking that could be another one that we focus on. And then the other major theme that came up that is within the initiatives is also improving the training in geriatrics amongst health providers with specific focus on ED certification in geriatrics, advanced practitioners, care practitioners. And Jenny just brought up, there's also a part in there about training the community paramedics to be able to have geriatric training. So that's sort of what I'm pulling out. Let me get some.
Sarah, on that last one, I might add geriatric clinicians as well, whether it be physicians or nurse practitioners or behavioral health providers.
Yes.
Big issue. So that geriatric education issue is pretty broad. There was a little bit, we're going to get cut off soon here, but there was also a little bit about access. I just want to acknowledge some in terms of special disease issues like cancer, but some in terms of access in general, or transportation and access, So, but I'll bless you in terms of cutting it down to 3 and consolidating it.
Sarah, the discussion about health exchanges and, coordinating actually the information, is that under your number 2?
Yes.
Okay, great. Because we definitely started
a lot of
strong with several comments on that. Thank you, Sarah.